Hello, everybody. Welcome to this seminar, to this little webinar of the NMS Club, which has been sponsored by the International Maitland Teachers Association. I thank you, everybody, for attending this webinar and for your interest. And my name is Ellie Hengeveld, and I will be the facilitator of this webinar, facilitating for myself. It is a bit strange because I only speak to my PowerPoints. You will see me, but I won't see you at the moment. I will go through the webinar, and at the end you will have some possibilities to ask questions in the chat. And one of our administrators will read your question, and hopefully I can give you an answer. So the topic is the Maitland concept and the Biopsychosocial Model. And as I said in the pre-announcement, which you may have read on Facebook, for example, or on Instagram, we as physiotherapists, we are very well trained in the procedures of examination and management of movement disorders mainly. But, and I relate the owner of the back to a statement of a Swiss philosopher, Hans Zahner, who wrote about foreign workers. And he would say, we expected workers, but in fact, humans came. And we can say, well, I think I'll treat the back. Oh, he has a back problem. But the owner of the back will always be there with their thoughts, their beliefs, their feelings, their expectations, their value system, and their whole context, from their biography and their life, from the social background. And all these aspects somehow are important in one way or the other in the development of our therapeutic alliance. And these aspects are in contemporary practice and in research quite frequently discussed, as you probably all know. So we will discuss today several relevant psychosocial factors as contributing factors to this experience of pain and disability. I would like to work with some selected examples, and then I want to discuss how we are moving from a split dualistic body-mind model of thinking towards a biopsychosocial thinking and client-centeredness. And in those discussions, I will always hear that's what we've always done. And I am fully agreeing with that. But I would like to say something about that too, of course. I will go through the yellow flags concept, and I will, towards the end, I will speak about aspects of the mature organism model and how we can use that model to reflect on potential psychosocial factors with our patients. That's me, how I look like now, at least in the summer. I'm a physiotherapist. I'm trained in the Netherlands, and I must realizing that for 2/3 of my life now I have been a physiotherapist. And I still like my profession because the profession has this diversity. There's so many areas where we can be active. And as I liked it in all my years of practice, I've studied many approaches to movement and therapeutic touch, which always had my main interest. And some of them I integrate in my daily work. What I like in the profession is that there's always something new to learn or to ponder about. And I hope that this presentation for you, that you find on the one hand confirmation of, you said, yeah, I've been doing that already, I think like that, that you may discover some new aspects as well. But I would also be pleased if you leave this webinar with new questions to ponder about, that you may say, oh, hey, let me think about that a bit more. So I'm very grateful that I got the Maitland concept in my toolkit, if you want to say that like that, in an early phase in my career. And as you probably all know, there are these 5 pillars of the Maitland concept, which are as relevant now as what they have been perhaps 40 years ago. This process of continuous assessment has been very helpful for me because I believe that assessment helps to enhance our awareness. And if we guide it with communication, it will also enhance the patients towards an aspect of self-awareness. From the beginning on, I liked the idea of progression of treatment, just meaning there are no standardized programs. We adapt the treatment to the specific situation of the patient. And if he is improving, then of course our treatment has to be adapting to it. This, for those who have done the Maitland courses, they learn early about the brick wall model, which is in fact a clinical reasoning model. For me, it was helpful to focus on what have I seen, what have I heard, what have I felt, and to put that in the center of my attention, and realizing that the theories and what I think about it are to be separated from that, because these are often interpretation and applications of theory for my given patients. Clinical reasoning is one of my pet childs. The hypothesis categorying or the categorization in the beginning already was very helpful for me, but now also I'm very interested in other strategies like narrative clinical reasoning, interactive and educational clinical reasoning. And on the person level, Maitland would always have said, I have a commitment to the patient. And we knew, communication is important. And since about 2 decades, perhaps, that we realized that it is an expression of a client-centered treatment. So in the first 15 years of my work, like I said, I have been studying several concepts of treatment. There may have been more patients who benefited from my work, but there were also so-called difficult patients. And then sometimes you get questions and perhaps you recognize some yourself. And so I started to think in the 1980s, beginning of 90s, is this psychological? But I was always doubting myself because I said, I don't want to be unjust in my judgment of the patient, as if it was a verdict about my patient. And then there were maybe those people who kept saying, oh, it's always the same, it doesn't change. And this sense of helplessness and hopelessness sometimes, where you just try to say, well, I better don't ask about pain anymore, but what can they do? How can I guide them to focus on something else? And then by the time that I became a teacher in about 92, I think, I saw myself back in some of the students, of course, and I learned a lot from that. Sometimes it seems as if when we ask questions in the subjective examination, where's your pain, when does it occur, as if our patients do get more pain. And I know that there was a discussion in the English journal in the 1980s that said, well, you shouldn't ask so much about the pain because they just get more pain. And I just sensed, no, that is not right, but searching for answers. So this guided, all these experiences guided also to a master's program, which I followed in London. And my thesis was related to the psychosocial issues of physiotherapists in Switzerland. And I sent out questionnaires to 100 manual therapists, and I had 10 interviews with physiotherapists. It was a qualitative research. And I'm still grateful that I followed that program, as the things which I learned and the thinking which changed are still lingering on, even 20 years later. Another aspect which makes why this Bio Psychosocial Paradigm is so close at my heart comes from the work with the clinical psychologist, a friend of mine, Roberto Brioschi in Switzerland, where we had a course in interdisciplinary management of patients with pain. And the center was always, how can we enhance the therapeutic alliance? And it was related with shared decision-making, or in German you would say Auftragsklärung. I lived in Switzerland till 2018, and now my husband and me, we built a house here in Wimberley in Texas. So I'm currently a bit challenged with the weather and electric outages and internet outages, but for now we are on the way. So let's ponder a bit on that question. Is it psychological? I don't want to be unjust in my judgments. It is so, it was always a bit linked with, it's psychological. And now I would say, yes, of course, it's also our psychology which makes the experience. But anyway, in the 1980s, there was still this strong specificity theory, an input-output model. If there's an abnormal output, like pain, functional limitations, even suffering and pain behavior, what is abnormal? Normalize the abnormal input, and then the output should be all right. And what is between the input and output, it was just a big question mark. And that's clearly an expression of a biomedical dualistic body-mind paradigm. And the orientation is very much positivistic, which means we have to make it always measurable, it has to be quantifiable. And of course, we know that a lot of our work in dealing with human beings is not that simple. If you look from the point of neurophysiology, it was always still linked to quite a lot of the so-called linear cable model. And there's this input here coming from the fire, and that leads then to the awareness of pain somewhere, someplace. And it always has this principle of causality. And what is the cause? And if there's someone with a problem, and we try to see, is there an issue in the tissue? Is there a pathobiology? Is there a dysfunction? And we would try to normalize that. But if we couldn't find it, we would infer then, okay, if it's not there, then it must be between the ears. And then at that moment, we may have thought mainly in the old psychoanalysis, is it a somatization of a hidden conflict? Are there biographic influences? Or he doesn't want to work and she wants attention. So these are aspects of secondary gain. Well, in that moment, that's of course quite judgmental. And that would have been unjust to say it's psychological. And I think we shouldn't forget that we have many patients who think like this and have sometimes quite a bit of difficulties when we try to explain their pain to them and try to somehow figure out some psychological aspects. And some people get really upset about it. Well, thanks through the neuroscience, where Meltzer and Wall with the Gait control theory had a big influence. They wrote in their booklets and in a lot of their publication, they wrote about phenomena of pain inhibition and about the necessity of pain, that religious ritual, acute injuries, that people would have a big injury, but they would not experience pain. So thanks to the gait control theory, which is a big process, it's not only a dorsal horn process, as we are often seeing, and there's between the hands, between the tissue and the ears, there's this whole network, neuronal network with their processes, ascending and descending processes. And the strength of the neuroscience in that time with this theory is that we can see pain can be the result of processes in neuronal networks. And that's, of course, for us very helpful in some aspects of our pain education nowadays. So let's go to another question. And those people who perhaps say, I rather do not ask about pain anymore, but what can they do? So, in fact, it was an endeavor that people would, that I would try to focus next to the pain also on their abilities. And too long we thought the disability is a consequence of the pain. And that may be, but not always. And it was the article of Gordon Waddell who wrote in 1987 that it is essential to distinguish between a construct, which is a shared experience, is a construct, that pain and disability may be related, but they're not the same. And that was, of course, very helpful. And this is just perhaps for something to ponder about, because we have the concept of pain, the construct of disability and ability, but also suffering. And when I showed this image once to a friend, a teacher in Switzerland, he said, "Oh, Ellie, do you also want to treat the suffering of your patients?" And I said, "No, but I should recognize it. Because if someone has a pain but doesn't suffer a lot, we may expect that the disability is obviously not too high. But if there is already a suffering, then it is possible that everything is much harder to bear. So it is good to realize how pain and disability can lead to suffering, to maybe anxiety and fear that you can't fulfill the role in your life anymore, which makes your identity. So all these aspects are always in the package when the owner of the bag comes in, some more, some less. And with this package, of course, we have to consider the pathobiology on the one hand, and with their expression, we get a grasp of their illness experience and their illness behavior, which has become quite a central part in my work. Thanks to I quickly have to check where I am. Yeah. So I believe it is very good to distinguish between the pain and the disabilities, and that we get the information about it in our subjective examination with our patients. I think the ICF, which I'm quite sure everybody knows, so I don't go too far in it, particularly the ICF helps us a lot in defining the core aspects, the objectives of our treatment. Related to movement functions, and the manual therapist or the NMSK physiotherapist is quite well specialized on that level. And our activities and the participation and the priorities of the goals are dependent on the individual illness experience of our patients. And how careful we want to proceed is, of course, dependent upon our understanding and insight of the pathobiology for a big part. So that is, I'm quite sure, nothing new. So sometimes you have those tricky moments, that you just say, where I observed students and myself that based on my questions that patients seem to be in more pain. And it's sometimes a bit tricky when they say, first the pain has to go, and then I look further what I do when I think of goal setting. Yeah. Or they will say, I am still in pain, nothing changes. Oh, it's always the same. And that this expression of a bit of hopelessness sometimes makes us also a bit hopeless too. And impatient because we may not always understand. So a lot of things will be also happening with us. And I like to work personally with some of my patients with this image of goal setting. That I indeed make this drawing. And when I ask, and it's important to realize, when I ask the patient, what do you want to achieve? And we're still on both sides of the road, the patient and me. And so what would you want to achieve, thinking when you arrive at your finish? And then they may say, everything is okay, everything is good. And when you ask them, what does that mean? They say, well, I should have less pain and I want to work again. Well, of course, these are aspects about pain and about already activity and participation. But the goals at those image, at the finish, that's often too vague. It's very hard for those people who always say there's nothing is changing. It's always the same. It's like as if the weather is always the same. That's not the case. And so an image like this might help in shared decision making. It's like, what kind of work are you doing? What do you need for this work? Which kind of, tell me a little bit. So you have to have this activity, that activity, and you can fill that in at the end of that model. And it is interesting that Veronica Schoep, she is from Switzerland with people also from England, that she did quite some studies in how physiotherapists do goal setting. And in this paper of 2014, one of the results is they did an analysis of 27 videos from physiotherapist-patient interactions. And there were 11 physios who were asking about the goals of the patients. But it was a bit tricky because physios appear to expect that the patient has already goals in their mind and that they understand what is relevant for us in physiotherapy. So, and that sometimes makes it, of course, a bit vague and too general. We have to help them there. So, also in one of their conclusions, patients may not know what is an achievable goal, but there may also be social reasons that patients do not dare to make claims what their goals are. It has to do also with the value system of the patients. So anyway, so that was something I started to ponder about in a bio psychosocial model of thinking. How can we go into goal setting? And then comes the question, are our questions leading to more pain? And important is that Fordyce, he was a doctor, and he is still highly valued for his work from the behavioral medicine. And he says it's important that we are aware that we are also observing the behavior of our patients. And the always sighing, that comes in our implicit intuitive reasoning, or looking away, or this tension, or those movements, lifting the arms in what we might interpret as a sense of hopelessness. And he says, look at those behavioral cues consciously. And in our thinking as hypothesis generators, they would say, and what kind of hypothesis gives that? Because it may be that we just start to think, I said, oh, there's more going on. Oh, that's going to be difficult. I guess he's going to be chronic. And you may be right in that thought. But what have you seen and what have you heard? What brings that thought, that hypothesis to you? And often there are those key gestures or the words patients use, or the intonation as well. And these are behavioral factors. And the behavior, like Nolan said, our behavior is always a sum of what happens physiologically, our cognitive, emotional, and social cultural aspects. And Fordyce, again, in 1976, I'm sorry, there's a typo, he says the central question should be, why does this behavior occur in your analysis and understanding, and not primarily think which pathology or nociception leads to this behavior. And that was very important to me. They said, yeah, what does he experience? What might be the reason that he or she is sighing so much? First, I have to be aware and notice that. So over the years, pain as an experience, as you all know, has many dimensions, but also many layers. If someone has pain, there are pathophysiological processes. There are also normal physiological processes. Yeah? And pain is always a package. It's not only pain. There may be a lack of energy. There may be a lack of initiative. At all those aspects, let me see where my notes are. A fatigue. Where are we going to place them? Do they have a memory? Some people, they may be very inactive. They play games, they watch television or do streaming. But if they have lost so much contact with life, they may not even remember what they have been reading or what they have been playing. And so pain has always more dimensions and layers. And we sometimes, with some patients, we have step by step unwrap that. And just as a side remark, in such a case, you can imagine that I'm totally unhappy with a numerical rating scale if people are allowed to say, how strong is your pain between 0 and 10? And they give some kind of a number. And to me, that means that this whole experience is reduced to a single number. And this unwrapping may be limited because of that. This is just something to perhaps ponder about. The dimensions are also cognitive, emotional, affective. It is also linked to our perception and sensation. There are these behavioral aspects, and that is a strong focus of my attention. And behavior is always also socioculturally and biographically influenced. So pain, like Meltzer-Campbell wrote and already in 1982, it's not just a function of the amount of body damage alone. That what we feel and how we feel is determined by our previous experiences and our memories of them. It's also by our ability to understand why it is there and to grasp its consequences. The culture influences that. And therefore, they say pain perception cannot just be defined in terms of particular kinds of stimuli. It is always a highly individual experience. And I will speak later that I have a suggestion that we take the illness experience of a patient in the core of our thinking. So out of this whole development, we got all those models, those psychosocial models, and John Loser was one of the first one in the end of the 70s. And the one on the right with those 5 circles is the Glasgow illness model, which was in fact described for the first time by Gordon Waddell again. And I think we physios are not bad in the subjective and physical examination of movement-related pain. Intuitively, however, we often, well, mostly intuitive, we react on the belief system and the attitudes, maybe not always positive. They said, oh, he's just not motivated. That's more likely the negative attitude. We understand there may be distress, but how can we communicate with our patients there? And the illness behavior is something we always observe, but how much is this an implicit part of our clinical reasoning, or is it also an aspect from what have I seen? Why do I think that this could happen with my patients? So the change towards the biopsychosocial model comes in fact from George Engel, who was a psychiatrist who said the dualistic biomedical separation is not only a problem for psychiatry, it's for the whole field of medicine a big problem. And he said you have to consider, next to the pathobiological process, also the influence of thoughts, feelings, and socio-cultural processes in illness and disease. And both Meltzer-Campbell and Engel, they probably were not the first, but they had the benefit of the time. All of a sudden, the time the audience was receptive to what they have to say. So if you now read articles about biopsychosocial paradigms, they will often relate to this article of Engel. And if you're interested and you may not have read it yet, just Google it and you will find definitely a PDF file we can download. It's interesting to read, I believe. Anyway, so we are working with the biopsychosocial paradigm. And lately I saw on an online conference that, of course, a person-centered paradigm. And we can't split up and we cannot always say how much bio, how much psycho, how much social. It is always in more or less aspects there. And on the one hand, we have, of course, then bio, the issues in tissues and dysfunctions. And on the other hand, are the owners of the problem, of the challenge, as a person with thoughts, with feelings, and it's acting and reacting within their context. And that is, of course, then related to the concept of red flags and also a concept of yellow flags. And particularly the yellow flags, I would like to emphasize that yellow flags are a contributing factor to a pain experience and pain behavior, but they are not causal factors. And I think that's very important because, and it is not a psychiatric disease that would be orange flags. So I'm coming there. So interesting is also with this change to the biopsychosocial paradigm that the definition of pain has been changed. In my physiology book in the 1970s in the Netherlands, it would always have said pain occurs in the presence of pathology or tissue damage. So pain and tissue were totally linked. But the International Association for the Study of Pain was founded in 1974, I think. And one of the first things was that they tried to find a better explanation or definition for what pain is. Well, we hear that often, of course. It is unpleasant. That's a bit of an understatement. And the good thing was that to say it's also an emotional experience. And it is linked with actual or potential damage, but described in such terms of damage. So it's a bit, they have to look for it to get a good wording, and not everybody was always happy with it. What is interesting, I think, for us, that the patients with whom we are dealing, that the pain and the disabilities may be linked to a sense of threat. And your threat system, very strongly under the midbrain functions, with your fight and flight reaction, can really lead to a stress reaction. You can imagine that I had quite some stress reactions over the last days when we started to get outages of electricity, and all of a sudden there was no internet and there was no telephone, and it's on and off. So this sense of stress, and in this case with threat, is, I think, for our conceptualization of some of the problems of our patients, important to keep in the back of their mind, in the back of our mind. Amanda Williams and Craig in 2017, they said, well, we propose a new definition of pain. And I like that they just said we need to emphasize that in the definition that pain, how it is associated with actual potential damage, that it has those biopsychosocial or psychosocial components in it. Well, last year the IASP has made a new definition. You can look it up on their website, which I recommend highly, because the terminology gives a lot of background information on their whole list of terminology. The basic definition, I feel, has not changed a lot, but they have some keynotes to it. It is a personal experience with biological, psychological, and social factor. Pain and nociception are not the same. They may be linked, but not necessarily. And people are learning about pain, and that's, I think, for us physios important. When I was a child, I learned about pain because I injured myself. I scraped that knee and it hurts. Or I may have had a bellyache because something was wrong there. So that is then with injury and illness. And then over time, to realize, and I learned that the first from Mackenzie when he came with his finger example, if you stay for long in the same position, your nociceptive system will be activated, but there's not necessarily damage. And to me, that's one of the most brilliant examples, which I like to use in the education of my patients, that our movement behavior can lead to pain, but not necessarily to tissue damage. And maybe we would think theoretically about acidic environments or whatever we have. Yeah? Central is also the experience of the pain. And sometimes there are those patients where I just can say nowadays, I couldn't do that 30 years ago, I said, I see that you are in quite some pain. What did that do with your life? What does that do? And so that I can acknowledge their experience. That at least, even if I can't help them, that I can, by the acknowledgement of that experience, that I can show empathy, and that they at least think, well, she tries to understand. And I don't know how it is for you, but I was once in a very difficult situation, and there was a person to whom I just could speak. In fact, it was my brother. And he just listened. He was not mental. And he said, yes, I see that is difficult for you. He was this active listener, and that was so healing in itself. And it was good going through that, because remembering that I can say, wow, I see you. You have gone through quite a lot of things. And from there, sometimes we can take it further. And we know all that pain has an adaptive role, but sometimes it seems to get alive on its own. And verbal description is only one aspect, and I think we should react on the intonation of people. Oh, it's always like this. The words they use and their non-verbal behavior, and that is quite an influence on the way how we interpret their whole experience. But it's often implicit. It's on the intuitive level. And intuitive reasoning is always there in our work. However, the more we reflect on that, the better we can develop ourselves. So, of course, we would say we are already biopsychosocial, and I fully agree. In my school in Rotterdam in the 1970s, we always had to say at random moments, human beings are socio-psychosomatic units, if I translate it well. You know, and it was such an automatic statement, and teachers appear to be happy when you rolled that out of your mouth sometimes. However, it was by meeting patients I started step by step to realize what that means. I don't know, I think I was too young to really grasp what this context might mean to the experience of people. So in my master's, it was quite clear in the interviews and the questionnaires that people did work with psychosocial aspects, but it was often without conceptualization, more on the level, there's nothing wrong with him. But if there would be aspects, it was hard to give that a name and to say, what are you doing with it? And Andrew Inry is a colleague from New Zealand, and he did almost the same kind of research as what I did, but now a couple of years ago. And his conclusion is, there may be more conceptualization, but it looks like that many physios still feel a sense of helplessness with the implementation. And I think we are learning step by step all together. And interesting is, this is a Swiss physiotherapist who wrote in the beginning of the 90s, he spoke about a paradigm change in physiotherapy. Well, we didn't even use the word paradigm yet, but he was ahead of time, I think. And he would say that therapists have an access to influence emotional aspects, even if this does not reach the consciousness of the therapist, neither the consciousness of the patients. And you just well or you think, so in around. We just see from some review on the knowledge and behavior of physios, and that is from 2016. You can see compared to 20 years ago, that we have more and positive attitudes to it, but we have implementing. There are some barriers, and I think becoming aware what might be part of this psychosocial realm next to the bio realm is probably an important aspect to grow into it. Well, pain is a dynamic phenomenon. It's often the influence of a direct social environment, and is an anthropologist. And Florian, his work of the kinesiophobia, their avoidance behavior. They say, Florian,
hello everybody from the back. it seems that the severe weather conditions in Texas have kicked out Ellie of her webinar. We'll try to get her back online, so please stay. And I think we should be back soon if the internet connection of Ellie is allowing that. So please stay online. Usually it takes just a few minutes to fix this. Let's see. Yeah, in the meantime, use the chat to share your opinions and thoughts and probably say hello to one or the other. There's a large international crowd again, very good to see, and a lot of familiar names as well. So thank you everybody for joining. It's a pleasure seeing you on our webinars on a regular basis. By the way, I will also post a link in a few seconds to our next webinar, which is Thomas Horde. It's a paid webinar, but it's 19 euros, and I can assure you it's worth it. You will be sent a link after that Thomas Horde webinar where you can rewind, go back and forth, and you can also access it for a longer time. So if you want to sign up, I've just posted the link. And by clicking on it, you can register for Thomas Horde, who will be on March 2nd. Good news. I see Ellie is coming back. So I will mute myself again.
I see a screen.
Excellent, Ellie. It seems
I think
you are back. So I will mute myself. Please do continue. Good luck with the internet connection.
Let me know where I stopped. So I guess René.
Yes, this is the place. That's perfect.
So I think it's important. Pain. Someone may have an acute nociceptive event, but within 2 to 4 weeks, Lyon and Crombez described that, of course, you get the psychosocial factors which start to play a role. If something doesn't get better, they may get worried, they may be a bit anxious. They say, I want to fly to Australia and I don't know if I can. And so these are all normal experiences, what people have, and we may need to address them. Sometimes pain becomes a metaphor for a whole package of life experience. And I like the study of Hashmi and others, and Vania Apkarian is always interesting to follow up. They did with about 150 people with acute and subacute pain, and let's say 2/3 their problem solved, let's say it like that, superficially, but 1/3 had ongoing pain and disability. And in the control functional MRIs, which they made, they saw that the representation in the MRI changed in this last group from just more the nociceptive areas to more emotional circuitry, which makes totally sense if we think that those brain representations are a representation of what we experience. Anyway, here comes a group around Peter O'Sullivan, the cognitive functional therapy group. Samantha Bunsley wrote years before already about behavioral therapy and physiotherapy, by the way. And yeah, their conclusion is, and it hasn't changed much, that we feel a bit helpless or unprepared to treat people with particularly ongoing pain or with psychosocial factors, which may hinder the recovery. And we may even sometimes stigmatize there or do not feel really prepared. And yeah, as a profession, we're trying to catch up there. just would like to see always, like many of you think, we always have some psychosocial aspects, because this little image of this little cartoon with this animal has his hand up and says, my wrist is hurting. That's sensation and perception. Then my fingers are getting numb. So who knows, maybe something vascular, something neurogenic. And he keeps sitting there and I say, I hope it doesn't get crossed. So we see some sort of cognitive, emotional statements here. But it might be when we are sitting there, because you might say, well, change, move a little bit, because we observe this behavior. And if we just give that suggestion and it leads to a sense of success, then we probably have not only had an influence on bio, but also social levels. And in my eyes, Robin McKenzie, with his repeated concept of repeat movements, has been very strong in that, even if he himself did not really like the part of psychosocial aspects of our work. But we shouldn't forget that his generation, Jeff Maitland's generation, they always had to prove that physiotherapy was specific. Yeah, and we are in a different era. This is one of my favorite cartoons. This is help-seeking behavior. And at the moment that you injure yourself, but there is no help available, Patrick Wall wrote about it, and it says people will have fight, flight, or help-seeking behavior. And at the moment that help is there, then it is possible that the inhibition is falling away. And I think this cartoon highlights that. And there it looks a bit like exaggeration, of course, but it is help-seeking behavior. So we can say, yes, we work with psychosocial factors, but it would be good as a whole group that we get more and more concepts with it. And I'm on my way with there. And so we would say it more in an excluding manner. But what have we seen, what have we heard when the thought comes, oh, there's more going on? And then what can we do with it? And sometimes it is finding nice and good words to refer a person to another professional, of course. We do not always have to do that ourselves. So there's a lot of the psychosocial reasoning is an implicit process. And I suggest to reflect why certain thoughts and hypotheses come. What are easy patients? What are difficult patients for you? I always like to ask it on the level 3 courses. And it's hard for my colleagues to say which patients they think are difficult. But easy patients, they say they are cooperative, they are motivated, they are interested, they're positive towards physiotherapy. They understand our processes of subjective and physical exam. They understand reassessment. And they do their exercises. So we can say the easy patients are the ones who do exactly what we want them to do. But do they understand? Yeah. So, can we have this discussion? What is difficult and how can we deal with it? And one aspect of the difficulties is patient may not always understand why we do something. Yeah. Are they aware that our paradigm, our central core of problem solving is related to movement? If they think I have a herniated disc and they still live in a paradigm that movement is bad for a disc, how will we approach that? Will we just say what you think is nonsense? Sometimes it looks like that because we just toss in a new explanation. Let's look at it. The waiting room. And you may have the patients, and probably, like Louis Gifford wrote as well, that many people will say, what is wrong with me? What can be done against it? And we physios always hope, what can I do against it? And how long will it take? And I think we should address these questions the latest at the beginning of the second session after our own reflection. And I think there will be quite a few patients who think, I'm not sure if physio is really the right thing for me. But they may be there because the neighbor said you have to go, or the doctor referred and said go in therapy. And sometimes they say, and it's particularly in Switzerland, yeah, the doctor sent me to the physio, but he didn't even make an X-ray. And that could be a yellow flag, which means I have to go and do something in the physio, but he didn't even examine me. He even sent me just straight away. It's a very important aspect to recognize and quickly discuss it. And then, all those young, pretty therapists, and then there's this 52-year, slightly overweight patient. He doesn't have a good self-image, and definitely he doesn't like training. And now he's sitting in a waiting room, perhaps in the middle of a training room. And all those pretty girls, oh man. Or that he thinks, I don't think I should be here. And then we just come and let me do your exam. Yeah. Or another aspect, because they may be in the old psychogenic model, I'm not imagining this. I hope that they believe me. So can I show that I believe that they have this experience? And there we go. I was just Googling a bit on images of physiotherapists, and there's this bright, young, pretty physio. It's lovely. And then it can be happening that just say, well, hello, my name is, and I'm your therapist. I will have to ask you some questions, and I will have to look at your back to see what is wrong with you. And I think that is the wording which needs some reflection, because if the patient has had an odyssey and went through many, many examinations, and then he was at a special clinic in Zurich, in Germany, and there was this empathic professor who took the time to give a clear explanation, then it is very well possible that they say, hey, this was a professor, this highly, highly regarded person, famous. And now this, she's just saying, looking what's wrong with me, he did it already. Yeah. So can we explain why we need to ask some question, that we look through the glasses of movement and movement function? Yeah. And that's the reason why we will do it. And one of the things which a colleague years ago said to me, that she said, oh, that's so terrible, and I hear you sometimes, because you do something on the back, and then you say, does it hurt here? And then you say, good, then I stay there. And that made me ponder and said, yeah, probably the owner of the back, I'm not sure if they say that is good. Yeah, that they may ask, why is she pushing exactly on those painful spots? And I just read lately that Joe Nijs, he's a Dutch guy, also a lot in pain. He said manual therapy and communication should go hand in hand. And probably it is good that you stay there, but get the owner of the back on board. So he may just need a brief explanation why you think it would be good. And the same counts for reassessment. I've had doctors calling me that said, well, I think it's not a good idea that your patient is doing this flexion exercise with his discs, in the 1980s. And I just realized that I may not have said, okay, now I'm done with treatment and I would like just to see how that becomes you. Yeah, I would say, and I see colleagues or students say the same, please get up and could you please bend over? And then perhaps the patient perceives that as an exercise. Why do I have to do this exercise over and over again? This is hurting me. So in the whole process of what therapy is, does the patient understand what we do and what we ask? Another aspect is in our biopsychosocial world is working with the patient belief system. And you may have seen that, depends on what kind of discussion groups you are. Here it's a bit an exaggerated example, but it is happening. It's the one-sidedness. Matt is a 40-year-old man. He loves running and football and spends time with his family. Now he has acute back pain, and he never had that before. He went to a doctor on the advice of his wife, and the doctor said, well, it's a slip disc, but sometimes you need surgery, but go to the physio. Yeah? If they can't help you, come back to me. And these are then sometimes those patients who said, the doctor said I need to have surgery. But that was not his thought. And then we patients, we may say whatever kind of explanations. We may not work with this diagnosis of the slip disc. What did that do with the patient? And he says, this therapist in this example, your spine is not well aligned. Well, you have a lot of tension here. Oh, you have a muscular disbalance. You're stiff. So he says, I'm totally confused. The doctor says it's a disc, and the physio said it was out of alignment. I'm just down. I just would like just to go running again. But the therapist said, be careful with your back. And what does that mean? It's of course very stigmatized, but it's good to ponder. So he thinks, well, I better rest. If I say I have to be careful, I better rest. And then he gets overweight. He goes back to the doctor. He gets a scan, but you don't get your results soon. And then he comes to another therapist, and he comes maybe one-sided with the multidimensional educational session that the pain is. And, well, that doesn't run off well. Not because it was wrong, but did we work with his system? So these are all examples of yellow flags. And yellow flags are defined already by Kendall, Linton, and Main in 1997 as those psychosocial factors of a normal human experience which may hinder the process to full functional restoration. And there are lots of them, and I'm not going to read through that, but they made just an acronym, the attitudes and the beliefs. And that's based on the research they found. The behaviors, had extended rest or disproportionate downtime. There may be compensation issues. The aspects of diagnosis. If a patient comes to a doctor and then to me, he gets in fact 2 different diagnoses. And that may be confusing. And it doesn't mean that, and so they need to know that there are different perspectives on their experience. And that we have to look at it from our diagnostic language, if we say it like that. And of course, there are always somehow emotions with it. There may be family aspects and work aspects. Now, there is this acronym, and they say the most important question is, what can we do to help this person to experience less pain and disability? And I just suggest download this this description of it. It's from 2004, and you will find it directly on Google if you use these search terms. Yeah. So let's bring those yellow flags a bit closer to home. And I like the mature organism model a lot because it's a cybernetic model that the input will be somehow processed, scrutinized within our self. And we will have a change in output, and that can be physiology with muscle tone, autonomic nervous system reactions, that can be stress reactions, stress hormones, or also change in behavior. And we will look at that. I adapted that model a little bit, and I only have the German one, so that we have input, there is physiological processing, there are cognitive aspects, emotional aspects, sociocultural aspects, and learn experiences. And that will lead to output on a physiological level and on a behavioral level. And if I do PAs on the back of a person, and they think, but why are they pushing there? It may be that I do physiologically the right thing, but that the little stress reaction which that evokes, because the patient doesn't understand, may lead to a contrary reaction. Or that they can say, this can't help, so why should that help in the reassessment? So let's jump over that. Interesting is that you see changes if we combine it more with patient-centered communication, that we see changes already in functional MRIs. So let's look at that. So if a patient comes to us, they will have an expression, verbal and non-verbal. In fact, kinesiophobia is a protective behavior, which is totally adaptive very often. We may have this fight or flight the reactions. So whatever that might mean, some people are a bit impatient. We see often the freeze reaction. Yeah, that is an indication of protection, freeze. Hypervigilance is a freeze reaction. Students sometimes say there to me, Elia, it must be irritable. I can't even touch and he is in pain. But it may be communication or also freeze. And we can work with that, with relaxation. And most patients will come with help-seeking behavior. We shouldn't forget once as a repetition, behavior is the sum of all these processes. And if patients seek help, there must be on an emotional level perhaps a sense of helplessness. They can't help themselves. That may evolve over time in hopelessness. And that is always somehow linked to a sense of control. And then we are in terms of self-efficacy and locus of control. So it is essential that we guide our patients from the beginning on, that they get a sense of control over their pain or over their well-being. And that may be something very simple, like a breathing exercise or repeated movements or a hot pack or a sense of control. And I think for the sense of control, we have to distinguish what we want to achieve with the exercises. A sense of control is something simple. It has to be applicable in daily life. And exercises in supine lying are often not very practical for daily life situations. Another aspect is the belief. Here, the green on the left. If a patient has different ideas about the cause than we do, that needs some communication. If he thinks it's a herniated disc, and we think, well, that's probably not the most important thing, we have to work with what the patient believes and say, okay, well, what have you read about it? What have you heard about it? Can I maybe offer you an alternative explanation? Or can I offer you an explanation how gentle movements and build-up fitness can help the disc? It's good to know how discs may have healing potential. It's the same about treatments. If someone says, I need a massage, fine with me in principle, but I want them to be active. So I first ask, what would you expect does the massage do for you? You need relaxation. Yeah, I understand it. And sometimes they say, well, it can't help because my hip was already operated 2 years ago, so why? And it took a long time. And so sometimes they don't have these positive expected outcomes. And we react often intuitively and adequately on it. But if we do it more consciously, we might become more effectively. We say, that's the purple thing now, we often say we have to take person's fear. I can't take people's fear, but I can guide them to more confidence in using their body again. And that might be so different. And when I ask a person sometimes, are you afraid to move? They say, oh no, I'm not afraid. But if I ask them, do you have confidence in everything? They say, oh no. And so sometimes it's just the wording to come to this construct. And then the topic of vulnerability and even traumatization sometimes. I just ask you, have you ever had a car accident or that you broke your leg? Well, if you had this car accident, even without injuries, you will be much more careful in the beginning when you get into a car. So you're hypervigilant. Your stress system is looking for danger signals. And sometimes people are even traumatized. When I had a lady who had 5 years ago a patella fracture, and when I asked her in the history, what happens? She started to talk in so much detail. I wanted to go shopping and I was doubting if I take the car or the bicycle. So the memory of that incident and the whole context was totally still in her consciousness, in her awareness. She described it as if it happened yesterday. And I regret that in those years I did not recognize that she may have had an aspect of post-traumatic stress. She didn't feel safe anymore. And yeah, the mild cases can be treated by physiotherapists. So a lot of the things we do and say may attribute or contribute to senses of stress, or also reduce senses of stress. And if you remember Gertie's lecture last week, she said that many nerve structures and the ganglia in the spinal cord or in the spinal canal, that they are adrenergic. They are receptive to stress hormones. And sometimes it's very important. If we reduce the stress, it is very possible that we reduce also the excitability to nociceptive processes. So I would suggest that we start to see the process between the patient and me as a process in which I have my reality and the patient has his reality. And that I acknowledge that they go through, they are in an experience of pain and disability, and that I try to guide them towards a health and well-being experience. So there's this bridge, and if we want to gap the bridge between the realities of the patient, that's then often what they call the intersubjectivity or third space, the acknowledgement of the patient's question and our communication skills like mirroring, asking questions, or say, oh, wow, yeah, I would be quite frustrated too if in such a situation. And the sharing of understanding. That these are then aspects of Rogers' principles of a therapeutic relationship. If you are authentic, that you can say, yeah, I would probably feel exactly the same. And this acknowledgement is, yeah, how has this been for you, that you have been in pain so long already? Just take some time, yeah? Or if they have their explanations and say, perhaps, that's just one suggestion, would you mind giving an alternative explanation and you just think about that? So my suggestion is that we somehow take this phenomenological perspective, which means the experience of the patient is central. And in a later lecture, I want to address this. On the one hand, we have to examine the movement sensitivity and activity intolerance. We learn about the ICF constructs. We learn about the illness behavior and the suffering, and of course, get hypotheses about pathobiology. And how could a health experience and health promoting behavior look like? It's more than symptoms and signs. Do they have confidence in the use of the body? If they have high levels of activity, do they need maybe some relaxation and stress management? Is it very low? Do they need maybe motivation to get more levels of fitness? Are they aware how they use their body in daily life? I've learned a lot out of Feldenkrais and Alexander technique, and I love to use that. And prevention and also active coping strategies is a process in itself. There are many patients with whom we can have our classical one-dimensional approach. We work on the impairments of the functions and we try to influence the nociceptive processes. As long as we check that they come back to the normal levels of participation and activity, that we see some patients come back because the self-management didn't work or they didn't do it on adequate moments. And some patients say, I didn't go back to work because I didn't trust myself to be so that fit already, because I have to function at least on 150%. So do they have confidence for that activity? And a lot of these patients, we don't need to be extra aware of different communication strategies. Shared decision making, there are many patients who will say, yeah, I fully agree, and they are sincerely agreeing. Yeah. And reassessment, they understand straight away what we want. They are there. But those who then start to feel and fall into the category of more difficult, we need consideration of pathophysiological processes. What is perhaps, and that's just hypothesis, which you fill in your reflection, what is their knowledge about what I have to offer? What are their beliefs? What kind of earlier experiences did they have? Emotionally, do they have confidence in using their body? And we get the socio-cultural context too. Yeah, is it within their value system? And we observe their behavior. And then we are asking, is that behavior still adaptive or is it maladaptive? If you protect yourself with acute nociceptive moments because something happened 3 days ago, then your avoidance behavior is totally adaptive. But if you say, oh, no, I can't put on my socks, can't carry any bottle of milks, and you ask, since when? And they say, oh, at least since 6 months. Since it was that acute, then perhaps this protective behavior becomes maladaptive avoidance behavior. And that may need a different approach. In this context, if we need to do if you say it's a multidimensional approach and I have to reflect it, then I believe it is important to realize until a certain time, communication was always considered non-specific, and that's just placebo. But if we link our communication with our so-called specific interventions, then all of a sudden, the combination may achieve very specific effects, which, as it looks like, might even reflect into the receptive fields of our central nervous system. So if I conclude, psychosocial factors, the yellow flags, are part of a normal human experience. It's not psychiatric disease. It is normal. Working with those aspects is considered nowadays an aspect of contemporary client-centered practice. And the Chartered Society of Physiotherapy has that in their practice recommendation. And as it looks like, it would be good if we conceptualize that more for our practice and that we reflect on that, as I hopefully explained sufficiently for this context. And that we see that how do we come to meaningful treatment goals in what we call nowadays shared decision making. So if you just look in the future, I saw on the list that the biopsychosocial model comes back, at least already in the lectures of Matthew Newton, when he asked the question, when is the bio more important than the psychosocial? And Stefan Schiller, when is the psychosocial is more important than the bio? And I'm quite convinced that those colleagues will give you also further inspiration. I'm working on a series of the contemporary practice with the Therapeutic Alliance, shared decision making, how to work with the illness experience, and other aspects, cognitive behavioral principles integrated into our work. And maybe there will come a time that either on this platform or another, that if you're interested, that you inform yourself. So I'm very grateful that the internet supported this everything so far, that there was only one little beep that I fell out. And I hope that you found some inspiration, that you found some confirmation. You said, oh yeah, I was doing this. And that you may have a few questions to ponder about. So, thank you very much. And I think I have to stop the screen sharing.
Thank you very much, Elif. The voice from the off back again. Yes, if you want to share your video with us and stop your screen sharing, I am already reading a few questions and I would read them out to you. And
Please.
I would, then I would start right away. Anne Hallacher is asking, you don't use the NPRS anymore? How do you assess changes? How about questionnaires? Or is it better to communicate directly with the patient?
These are very interesting questions. Yes, I do sometimes use the NPRS, but only if it's meaningful for the patient. But what I would like with some patients, that I use metaphors. And I learned that years ago of a woman who was a professional painter, a very eccentric woman. She would always make a certain drawing, and she said, now this color is in it, and now it is this. So sometimes I make a sort of a metaphor. If your pain is like the weather and the barometer towards storm, where is it now? If you could give your pain a color, how's the color? Do you see any shades coming in it? Hopefully not of gray, by the way. Yeah. So in finding different metaphors for the experience, because the number 7 out of 10 is in fact also a metaphor, but it is a very rigid one. It's not linked to a story. So sometimes I take those things more, and that's part of narrative, the narrative work, and it's very fun because it is often that step by step the work which we do together becomes an exploration, in my eyes, in a more fun way than when I just technically ask, well, give me a number now between 0 and 10. Even if statistics from research state that it's a valid change if 2 numbers are improved, but it's only valid for those who understand those numbers. I hope I responded enough to it, Anna.
Thank you very much, Ellie. Ellie, if your internet connection allows it and you want to share your video with us, that would be great. In the meantime, I will read the next question from Vanessa Caldwell. What are your thoughts when patients are focused on investigations and or imagery?
Good question, because there are different situations which come to mind. In Switzerland, people, if I can compare that really, but in Switzerland you have to see that every doctor has an X-ray machine in their private practice. So the expectation seems to be that patients expect that they make an X-ray. So when a patient in Switzerland says to me early, well, the doctor, I often explain in the beginning that we look at their problem through the eyes of movement, and that movement, if movement functions get better, that arthritis or disc problems may stabilize because of that, taking their example. And so I said, is this what you expected? And it's possible that the patient says, oh, but the doctor didn't make an X-ray. In fact, it could be that they think that it is that it's necessary. They have not been investigated enough. So that's a process then that they say, well, you know, there's so many people, like you know from the courses, there are so many people who have lots of pain, but you don't find anything in an X-ray. And sometimes you see X-ray changes and people are totally happy without pain. So I think that your doctor really thought there's not necessary. But I would suggest, and then I negotiate a cooperation with me, that I would suggest if you feel after 3 treatments that you still need that X-ray, just tell me. Because often after 3 times they know what we are doing and they may start to feel some benefit. And then I'm committed to come back after 3 times. I make a note that they say, okay, when we started therapy, you said you thought you would have needed an X-ray. Do you still think it's needed? And so in that way, I take a bit the side of the doctor, who obviously decided not to do that. But also, if the patient is vehemently that it wants to have this X-ray or MRI, and that blocks my treatment, then I feel I need to contact his doctor. But that's more rare. It did happen, but not often. So I hope that is a bit of a useful answer.
Thank you very much. We have two questions from Thanasis. I will read out the first one. I have a question regarding shifting attention from pain towards function. How practically achievable or theoretically sustainable this shift can be while the patient seeks help because of pain, and while I, as a physio, I work with pain using PAs or exercise.
Well, that is what I try to express with the image of goal setting. It is with quite a few patients necessary, and I like the drawing because it is playful, but also it gives a bit of a commitment. They say, okay, because pain is important. I do not speak about their experience. But they say, well, next to pain, it's also what people can do and not can do. So let's say when you achieve that finish, how does that look like? What kind of activities would you be doing? And I didn't open the file, but I asked patients that the pain and what kind of activities are there at the finish. And that they fill that in themselves, or we do that together. And with some patients, I may explain the process. Well, you have been so long in so much pain. And of course, I do my best to help you forward. But sometimes you do something which you enjoy. Let's say you said you want to play with your grandchildren. And then you may have a day that you say, oh, I've had so much pain. Yeah, and that can take your whole awareness. That's in your mood. And you may have even the feeling that nothing changed. And if you tell me then that you're able to play with your grandchildren, but the day after that you have more pain, then maybe I will be the one who can show you that playing with your grandchildren and this pain are linked, but it's often very valuable to do so. It's a process in itself. I can't go in much detail, but it is attainable, it is possible. But, you know, like a PA is a technique. If you do a 4- or 3-, this kind of communication and conversation is a technique in itself too. It's not just that you have this kind, that you just have it. I definitely didn't have it because I was years ago this activist therapist who was very directive. And I think I've learned a little bit. So, yeah, that's for the moment how I can answer. But it's a central point, and it's good to reflect on it. And definitely it has to do with shared decision-making. So the second part of the question. Mario?
Okay, Mario, the second voice from the back is at the moment how viable it looks like. So I will try to answer the question. Not to answer the question, so read it for you. Does the biopsychosocial model have no limitations? Tanasi is asking. Thanks.
Yes. Yes. Every model has its limitations. And that what is discussed in science, it will always be hard to see how much is bio, how much is psycho, how much is social. It's just an endeavor to explain what people are going through. And it's an endeavor of bringing things together. But I personally would say the largest limitation are the clinicians working with it, because they have to translate it towards their own professional descriptions, like we. How can we translate it to movement, to touch, and work with that? And how much each aspect is linked, it will be personal, from person to person different. That makes our work so interesting, makes it challenging, but therefore I still like doing this work even after 40 years. Sometimes I just don't know how to help someone, but through explaining, hey, I see you're in much pain, but I don't think I can help you. And I suggest then perhaps somebody else. That the empathy helps them already to come to a slightly better understanding. So yes, there are definitely limitations to our own work too, as a person and as a profession.
Perfect, Ellie. We just received another question. If you're still up for it. It says in a recent podcast about EBP and pain science, the guest said during the patient's interview, usually the clinician does not let the patient talk for more than 15 seconds, and suggested to let the patient
That's long.
for at least 1 to 2 minutes in order to let him or her tell his or her story, so that we can make him feel or she feel that she's heard, and then continue with our questions. What's your opinion on that?
Can be very valuable. If I have had a sprained ankle 5 days ago and I want to go to my physiotherapist, then I would be a bit irritated when they would come watch the story. Yeah. But if I know already that someone comes to me because they have persistent pain, because they have tried a lot, then I may ask them, just tell me what you want to tell me. I first want to listen to you. And then we'll see what comes. And it is interesting, I'm in contact with 2 American physical therapists, because Gertie Bucher and me, we are working on the new editions of the book, and we are looking for some American authors. And one of the guys, Mark Cargilla, he is one of those people who works a lot about the narratives. And we want to work there to say, okay, how can you work with the distinction? When can you just follow your semi-structured interview? Because Mark Cargilla said Maitland has been ahead of his time. Our semi-structured interview gives us a lot of possibilities to go into more depth of narratives, or to stick just to your procedures of the body chart 24-hour behavior, which you always should keep in the back of your mind. So yes, I hope this answers it. It's a big topic, which would be very nice if we can just discuss it in a face-to-face meeting, because I can't see the person who asked the question.
Wonderful, thank you very much. Looking at our time, we have answered all questions, it seems, and we did it in time. Thank you very much from my part. I think we have come to the end of this very interesting webinar. Thanks a lot to you, Ellie, and thanks a lot to everybody who joined us today.
Welcome.
And I'd like to remind you once more, on March 2nd, Thomas Hore is up next. I posted the link to register for that webinar. That's the next in line. So Ellie, I will mute myself if you want to say some final words to the audience. For me, it's a good night to everybody if you're in the same time zone as me.
Well, thank you everybody for your interest, and for still quite a few people who have been hanging in till the end. And hopefully we meet each other at one place, online or physically, in whatever kind of meeting. All the best to you, and for you guys, sleep well soon. Thank you so much for being there.